So as we wait to get started, there are a few slides you can look at. Please read the slide describing how to choose your preferred language for tonight's event. Please be sure that you click on the globe at the bottom of the screen and then select the language you want to participate in the meeting. If you're on a mobile phone, click on the 3 dots on your screen, then click Language Interpretation and pick your language. This includes English speakers. Everyone must choose a language. Welcome, everyone. If you've just joined, there are a few slides on the screen. As we wait to get started, please read the slide describing how to choose your preferred language for tonight's event. Please be sure that you click on the globe at the bottom of the screen and then select the language you want to participate in the meeting in. If you're on a mobile, click the 3 dots on your screen, then click Language Interpretation and pick your language. This includes English speakers. Everyone must select a language for tonight. Welcome, everyone. If you've just joined, there are a few slides on the screen. As we wait to get started, please read the slide describing how to choose your preferred language for tonight's event. And be sure that you click on the globe at the bottom of the screen and then select the language you want to participate in the meeting in. If you're on a mobile, click on the 3 dots on your screen, then click Language Interpretation and pick your language. This includes English speakers. Everyone must select a language. People are still signing on, so we'll get started in a few minutes. Great participation tonight. This is wonderful. Welcome, everyone. Bear with me one more time. I'm going to repeat the instructions. As we wait to get started, please read the slide describing how to choose your preferred language for tonight's event. Please be sure that you click on the globe at the bottom of the screen and then select the language you want to participate in the meeting in. If you're on a mobile, click on the 3 dots on your screen, then click Language Interpretation and pick your language. This includes English speakers. Everyone must select a language. There are a few people that have just joined, so if you can click on the slide that best represents the language you want to participate in, please be sure that you click on the globe at the bottom of the screen and then select the language you want to participate in the meeting in. If you're on a mobile, click your 3 dots on your screen and then click Language Interpretation and pick your language. This includes English speakers, so please select your language now, and then we'll get started. All right, Dr. Singh, let's go ahead and get started. Hello, everyone. Thank you for joining us, A Conversation with Experts, the COVID-19 vaccine and children. This is an opportunity for us to answer some of the top common questions from the community on the COVID-19 vaccine for children. My name's Kelly Mead. I'm the Associate Dean of Academic and Clinical Affairs, and I'm also Interim Chief Medical Officer at UCSF Benioff Children's Hospital, Oakland. And I have the pleasure of welcoming everyone and introducing tonight's event. Before we start, we'd like to provide a land acknowledgement. We'd like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together, growing as a community, and we thank the Ramaytush Ohlone community for their stewardship and support. We look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. I would also like to acknowledge that tonight's event is sponsored by the UCSF Collaborative to Advise on Reopening Education Safely, also known as UCSF Cares. It was developed in collaboration with the Center for Child and Community Health. Tonight's panel is part of a series of activities and events being conducted by the Center for Community and Child Health and UCSF Cares, with strong partnership from San Francisco USD, Oakland Unified School District, and Alameda County's early childhood education on advising around learning in the time of COVID. Now I'm going to hand this off to Dr. Dana Long, UCSF Professor of Pediatrics and Director of the Center for Child and Community Health for UCSF Benioff Children's Hospitals, who will be moderating tonight's event.
Thank you so much, Dr. Mead, for the introduction. And I'm here to welcome all of you to this conversation. And we really do want to make it a conversation with all of you and with our community. Our goal is that we keep everybody safe and everybody in school. So we are really pleased tonight to be able to have a panel of experts who are here to answer some common questions about COVID-19 and the vaccine for children. One of the reasons why this type of conversation is so critical is because we don't want to leave any single person behind. I am a member of this community. I have 3 school-age children who are either vaccinated or have appointments to be vaccinated now that we are vaccinating 5 and up. And I want every single child to succeed. This webinar is giving everyone unequal access to high quality information about vaccine safety. And we really have assembled this all-star cast to talk to you about science and research. I want to acknowledge that a lot of parents are hesitant, and parents are hesitant because it is our job as parents to protect our children. We understand that there's often skepticism about healthcare institutions, and we have to earn trust. And so this event is one way that we are trying to come to you in order to earn your trust and be those trusted messengers and be open to conversation. So tonight is about answering questions. Please do utilize the Q&A on the Zoom in order to type in your questions, and we will try to get to as many as possible. So I would like to introduce you to our panel. We have 3 experts who will be speaking to you. The first is Dr. Parachi Singh, a professor of infectious disease. The next is Lisa Arcilla from cardiology, and then Martha Tessafal from OBGYN. We do want to share some basic information about the science and research of COVID in children. And so I'm going to pass it to Dr. Singh to really give you an overview, and then we will launch into our question and answers. Thank you, Dr. Singh.
Thank you, Dr. Long. It's a pleasure to be here. And if you can visualize about 270 of you in a room full, excited and eager to learn about COVID-19 updates and particularly vaccines. So it's certainly my pleasure to be here. I am a pediatric infectious disease specialist. I work at UCSF Oakland primarily. I see children, and in my other time, I'm also a mom of 2 kids, one of whom is going to get vaccinated on the 18th. So I'm super excited about that. I want to start with just setting up the landscape of what we have seen in kids in terms of COVID-19. And this is particularly talking about kids and adolescents. And when Delta came around, there was certainly a higher incidence of hospitalizations in US children since the rise of the Delta variant. And you can see the dark line is essentially all kids 0 to 17, and the dashed lines are different age groups. And all age groups kind of saw that little bit of a spike. And what was stark to me was that when CDC looked at particular hospitalization rates for adolescents, 68 hospitalized adolescents in which COVID-19 vaccination status had been ascertained, 59 were unvaccinated, and 5 were partially vaccinated, 4 were fully vaccinated. When we look at kids who have been hospitalized with underlying medical conditions, almost half, so 46% of them, had no known medical condition, followed by 35% of them had underlying obesity. And you can see a smattering of other underlying medical conditions like cardiovascular disease or gastrointestinal disease were less often known. And I want to allude you to a system that you might have already heard about, but multi-system inflammatory syndrome in children, or MIS-C. It's systemic inflammation that oftentimes occurs about 4 weeks after you have symptomatic or asymptomatic COVID-19 infection. We see this in adults and children, but in children, we call it MIS-C, or C for children, or in adults, we call it MIS-A, A for adults. When we look at MIS-C cases throughout United States, there have been about 5,200 MIS-C cases in kids and total of 46 deaths. You can see the blue line here is MIS-C cases, and the dashed line is the number of COVID cases. So as COVID cases increase a few weeks following, we do see a rise in MIS-C cases. And when we look at the racial and ethnic distribution of MIS-C cases, it's quite apparent that Black non-Hispanic children are higher affected than other racial and ethnic minorities that we look at. And then when I look at MIS-C by age group, you can see the 5 to 11 age group, that's 40% of all kids with MIS-C that have had MIS-C, which is the highest sort of predominance of population in the 5 to 11 age group. The outcomes, when you compare MIS-C with severe COVID, they have longer length of admission, meaning they stay in the hospital a little bit longer. They have about even ICU admissions, so they can be hospitalized and even ICU admissions. And that's 10 versus severe COVID, a little bit less than that. In terms of post-hospitalization course, this particular study that looked at 45 kids, their inflammation in terms of their body normalized about 4 weeks, about a month later. And when they looked at their heart findings, about 18% of them had normal coronaries in about a month. Why consider COVID-19 vaccination in children? A lot of people ask that question. So to put in context, 5 million kids have been infected, over 20,000 hospitalization, and almost 5,000 cases of MIS-C. Pandemic continues to take a toll in all facets of their lives. Children's mental health, emotional health, social well-being, educational experience has been greatly impacted. And 1/3 of adolescents aged 12 to 17 hospitalized with COVID-19 require intensive care, and even 5% of them require mechanical ventilation. So when we look at some other disease entities that we routinely vaccinate against, and this again here is the age group and the time period that we look at and hospitalization burden. So these are routine vaccinations that your children would get. And you can see the COVID-19 hospitalization burden is quite high. And when you look at deaths per year, even still, COVID-19 deaths per year, 66, as compared to the meningococcal vaccine that our children routinely get, or the chickenpox vaccine, the varicella, rubella, and rotavirus. So I wanted to share with you certain data that came out, particularly looking at the 5 to 11-year-old vaccine age group. So initially they did a phase 1 study with a few participants, and that was just to look at the dose or efficacy at a lower dose. Can we generate the same immune response as compared to the higher dose, the 30 microgram? And they verified that yes, and I'll show it to you in a slide later, that they were able to generate the same amount of immune response to the vaccine with a lower dose. They randomized it to 2 to 1, so 2 2 would get the vaccine and 1 would get the placebo. And they looked at in several different sites, United States being one of them. They looked at dose 1, 21 days later, they gave the dose 2. And then they did a 1-month follow-up for all non-serious adverse effects. They did a 6-month follow-up for all serious side effects. And then they also did blood draws in terms of immunogenicity, meaning if the vaccine was effective at all in order to prevent COVID-19. So this is just a slide to essentially show you that same amount of antibodies were created with 10 micrograms versus this 30 micrograms in the older age group. And this is the vaccine efficacy. Essentially, the blue line is the COVID vaccine, the red line is the infection. So you can see it was about 90% effective in not getting COVID-19 as an infection. So there were 3 cases in the vaccine arm and 16 cases in the placebo arm. And this question comes up is when my kid has already had COVID. They already have antibodies. Is it going to be beneficial for them to even get the vaccine? And this particularly looks at that. So they look at day 1, and this is 1 month post dose 2. This is again the dose, and these are the kids in green who have already had COVID, and pink are the kids who didn't have COVID before they got the vaccine. And this is essentially measuring the amount of neutralizing antibodies, which is effective in preventing COVID. And the kids who had it were able to generate those nice neutralizing antibodies with the vaccine that they got. In terms of side effects, we all worry about them. So after dose 1, 5% of them had fever. Placebo group that did not get the vaccine also had fever. Dose 2, a little bit higher percentage of fever versus the placebo group who did not get the vaccine. In terms of fatigue, they're kind of similar, you can see, and that's why it's important to do placebo-controlled studies, because you can see that it's probably not all vaccine related. And no cases of myocarditis or pericarditis were reported in this study, though it was not powered for this. Looking at myocarditis in particular, and this is for older age group, not for the 5 to 11, because like I said, they did not report any myocarditis associated with that particular age group or vaccine. There have been about 1,600 preliminary cases that have been reported. 77% have recovered from it. 34 kids were never hospitalized and only seen in the emergency room or urgent care outpatient settings. And then cardiac MRI, which was not always done, was abnormal in some percentage of the cases. And this was, I thought, was really important to highlight here, is that they actually also looked at deaths in less than 30 years of age. Total of 9 deaths was sometimes reported, but maybe it's associated with myocarditis. CDC did an in-depth evaluation to actually see if it was associated with mRNA vaccine, and none of the causes were associated with the vaccine. They could find that 1, it was either not myocarditis, or 2, it was another cause was associated for that myocarditis associated death. And then risk of myocarditis ultimately after the second dose of Pfizer vaccine was reported to be 54 cases per million doses of the vaccine administered to males between 12 to 17 years age. That convinced me. When we look at risk and benefit, so in terms of the recent surge, it would prevent about 56,000 cases. It would prevent over 100 hospitalizations, over 130 cases of MIS-C, and about 60 to 70 ICU admissions. While some people would argue Delta is going away, CDC even looked at pandemic average, and it would still be about over 18,000 cases of COVID-19 prevented, 80 hospitalizations, 42 MIS-C cases, and 26 ICU admissions, versus the risk of rates of myocarditis after vaccination with 5 to 11, which is largely unknown. So this is where I kind of do the risk versus benefit. Benefit, prevention of COVID-19 cases, likely prevention of hospitalization, MIS-C, and deaths, and post-COVID conditions like long COVID, possible prevention of transmission, greater confidence in return of safe schools and social interactions, versus the risks for myocarditis, which again, the study did not show any cases of myocarditis, and perhaps some short-term reactogenicity like fever or fatigue. So this is where I would end and perhaps open up to the panel discussion to bring in more questions and happy to answer them.
Thank you so much for that great explanation of COVID and the vaccine in children. And so, Dr. Singh, you and I are going to engage in a little back and forth. I have a number of really great questions. And I know that you just went over some of this information, but if anyone is like me and has that mom fog or that dad fog brain, sometimes we have to hear things a number of times. And so the first question that I want to ask you is, there are people who are worried about their child who has underlying medical conditions that might preclude them from getting the vaccine. Are there any medical conditions that are not associated with getting the COVID vaccinations? Any reasons to not get it?
That's an excellent question. And you're right. Vast majority of the kids are healthy, but certainly there are others who have underlying medical condition. And I would say that in particular, I would strongly recommend getting the vaccine if you have an underlying medical condition or that makes you a little bit more vulnerable to COVID-19. There's even suggestions to think that you might even need a third dose to help your immune system a little bit more, but we're not there yet. And I would say that without hesitation, I would in fact encourage parents to get the vaccine if particularly your child is vulnerable or has an underlying medical condition.
So what are the risks of the vaccines? What are the downside compared to the risks of COVID in kids?
Right. So the risk of COVID would be getting hospitalized, having MISC 3 to 4 weeks later, even if you had an asymptomatic infection, and long COVID, which we don't much know in kids, but certainly it's been reported. It's very minor. Versus the side effects from the vaccine that have been reported are fever, fatigue. I'm not feeling so great for like a day or two. So to me, it feels very much abundant in favor of vaccine to say that, yes, my child is not going to feel great. I'm going to do some warm snuggles and hugs for a day or so, but I'm not going to have to worry about, the long-term complications that may arise from COVID-19.
Thank you so much. And what about children who have allergies to eggs or peanuts, serious types of allergies, or allergies to antibiotics like penicillin or Bactrim?
Yeah, that's an excellent question. So right now, CDC recommends that you should get vaccinated if there's a history of severe allergic reaction, but not like if you have severe allergic reaction to like food, pets, venoms, environmental latex allergies, you still are safe to get vaccinated. Even eggs, gelatin, latex, or other preservatives. None, it doesn't contain any metals. And then one of the other things that kind of came up recently was polyethylene glycol, that's one of the components or ingredients for the vaccine. It's a very common product. If you have ever given your child Miralax for constipation, it's just that. So if your child has tolerated that, you should probably be able to tolerate the vaccine.
Awesome. And so let's say I decide to go ahead and vaccinate my child. As you know, all of our kids are wearing masks in school. If I vaccinate my child, do they still have to wear a mask?
So this is one of those short-term versus long-term answers. So in the short term, I would say yes, your child would probably still need to wear a mask to school. As we achieve more vaccinated population, as we drive this virus down in the community, I would say that CDC and even our local, public health guidelines would change accordingly.
And so you talk about these guidelines, and the holidays are coming up, which is just a really special time for families.
Yeah.
What kind of guidance do you have about holiday get-togethers that are indoors?
Sure. So if you go by the guidelines and the CDC, and I would say that I think they're erring on a side of utmost precaution, especially during holidays, especially during congregation times, and they do want everybody to be safe. There are certain cases of breakthrough infections. So I would say if you are gathering indoors, and particularly outside of your immediate circle or family members that you don't stay with, indoor masking is encouraged. Luckily, we live in California and the weather is great most of the time. So I would feel comfortable without masks outdoors, but indoors, I would still recommend masking just to be on the utmost safest side. I feel like things might change as we go along and vaccinate more in the community, but right now that's would be my recommendation.
So let me summarize those recommendations in practical terms. And so we should be eating our Thanksgiving turkey outside.
If possible, yeah. Do plenty of heat lamps and other things, and just outside. Outdoor transmission is very, very, very low. And if especially you're vaccinated, it should be okay to do that. Indoors, a little bit higher risk.
So my 17-year-old received his second COVID vaccine, his Pfizer, in May. When should we expect that our 12 to 16-year-olds might need boosters?
I think that data is currently being looked at right now with ACIP, which is the Advisory Committee for Immunizations, and that's affiliated with CDC, and they're going to look at that right now. What I would say is that I would not lose sleep over thinking that my child has lost their immunity from COVID. By and large, the largest kind of benefit from boosters has been shown in greater than 65 years of age, or those who have a wonderful immune system. So I would feel still comfortable sending my kid to school if, or mingling or other things as they're vaccinated, because we know the studies show that you still maintain your immunity, and particularly for that age group.
Great. So we had a surge, as you know, in August. And as a pediatrician working in a clinic in Oakland, I can tell you that we had many children who were positive. So if you have a child who was positive, then what does that mean for them getting a vaccine now? Can they wait?
Right. So the recommendations right now, if you have had COVID but you're outside of your isolation period, so generally 10 days or 20 if you're immunocompromised, you should get vaccine, because vaccine immunity or even hybrid immunity is kind of like the best shot ever. And when you look at currently, there was adult data that came out that vaccinated people or adults who had COVID-19 infection were 5 times less likely to be hospitalized than unvaccinated people. So it still provides you with really good, robust immunity. It's sort of like, the way to think about it is wakes up the part of your immune system that interacts really well to create those nice antibodies to fight that infection. So, and then the natural immunity in terms of like it wanes over time also. So yes, you're protected for some short duration of time. We don't know how much, but vaccine definitely gives you that higher boost and protects you over a longer period of time for sure.
So there are some 11-year-olds who weigh as much as 14, 15-year-olds. And there are some 11-year-olds who will be turning 12 in January, February. Should they be waiting until they're 12 to get a higher dose of the COVID vaccine?
That's an excellent question. So right now, the recommendations are that they should receive age appropriate. And I would not recommend delaying the vaccine until they're 12 years of age to get the larger dose. Vaccines work by triggering the immune system that evolves with age, not weight. So there's plenty of 11-year-olds that were actually included in the vaccine studies, and they had excellent vaccine efficacy with a 10 microgram dose. Also, so if you're worried, like on the other side, where it's like, there's if your child has over 99 percentile BMI, or there's obesity and other things. 11% of the kids who were enrolled in this study were obese, and they still generated good amount of. So you can go either way. You don't need higher dose, and you actually don't even need lower dose, thinking about both sides. Go with your age, not weight.
Thank you so much, Dr. Singh, for answering all of my questions. And I could ask you many more, and I'm sure that there will be, but I do want to bring our other experts into the conversation. And as you come into the conversation for our experts, please take a minute to introduce yourself. And so I have a number of questions for Dr. Arcila. And Dr. Arcila, do you want to come introduce yourself? And then I'll start peppering you with questions.
Hi, my name is Lisa.
Hola.
I'm one of the pediatric cardiologists at Oakland Side working.
Cardióloga
I'm also the very
y
proud
pediatra
parent
también.
of two
Y
freshly
también
vaccinated
pues estoy
5-year-old twins.
orgullosa de dos niños gemelos.
And I take care of a
Estudian.
lot of the acute COVID and MIS-C
Y
patients
también estoy cuidando a los niños que les ha dado COVID.
associated myocarditis. So I'm happy to
Así es que
elaborate on those
también
questions.
esto, también
Thank you so much, Dr. Arcila. And
gracias, doctor.
so I have a number of questions for
Tengo
you.
una serie de preguntas.
And so the first question is,
La primera,
can you tell us more about
¿me
myocarditis?
puede
Dr.
decir
Black?
algo?
Okay. So myocarditis is a general term for inflammation of the heart. And myocarditis in association with the COVID vaccine, as Dr. Singh showed in her slides, is incredibly rare. It was seen about 50 cases per million of the second dose administered. Typically that higher number, that was the highest number we saw, and that was in adolescent males. And teenage males are the group with the highest risk of myocarditis at baseline. Almost everything can cause myocarditis. Almost every virus can cause myocarditis. Lots of medications can have a side effect of myocarditis. And in fact, what we saw with the vaccine is that the vaccine-associated myocarditis was quite mild in comparison to the myocarditis or heart inflammation or other impact on the heart that we see in patients with acute COVID and especially in patients with MIS-C, the post-inflammatory illness that Dr. Singh alluded to earlier. So for patients with MIS-C, about 60% of those kids have cardiac involvement. And so when you were talking about our surge back in August, we were seeing a slew of those children as well as
nuevamente empiezo a hablar.
children with acute COVID.
Entonces estaba viendo niños pues con COVID.
Thank you so much, Dr. Arcila. And so I'm wondering if you could talk a little bit more about that multi-system organ disease that we saw when kids unfortunately have COVID. And what about vaccinations for them? Should they be vaccinated?
So current CDC guidelines are that children who had a history of MIS-C should wait 90 days before they get their vaccine. And that decision should be made in conjunction with the cardiologist if we're still actively following them. But what that is based on is that the long-term studies of children with MIS-C have shown that the majority of those 60% who had cardiac involvement recover within 30 days, with the tail end, the few who didn't recover during that timeline, taking up to 3 months to recover.
I see. And so is the same true for children that had myocarditis or pericarditis? And now this we're talking about after the vaccine. Should they get vaccinated?
So the patients who had vaccine-associated myocarditis, that typically arose after the second dose. And so it's actually not really something that we're dealing much with. I haven't personally seen any cases of vaccine-associated myocarditis after the first dose. It would be rare. But if that was a concern, those patients should again make that decision in conjunction with their cardiologist to make sure that they're ready to receive their second dose. But my concern would be that the rates of myocarditis with acute COVID itself are around 12%, and the rate of cardiac involvement with MIS-C, which is the higher risk for this age group that we're talking about, age 5 to 11, like I said, is around 60%. And so ultimately, we're more concerned about protecting these children from COVID and MIS-C than the risks associated with the vaccine.
Great, thank you so much. I'm going to bring our next expert into the conversation. And again, I'm going to have Dr. Tesfalou introduce herself, but I know that everyone is on the edge of their seat to know, what about pregnancy? What should I do? And so Dr. Tesfalou, I'm going to pass it to you to introduce yourself.
Great. Hi, everyone. Again, my name is Dr. Tesfalou. I'm a maternal fetal medicine specialist, also known as a perinatologist at UCSF. I specifically did a specialty or training in obstetrics and gynecology, and then additional training to be able to take care of patients at high risk of or who do have pregnancy complications. And these questions around COVID vaccination have been ones that I've been answering, not only for patients that I've been seeing both at UCSF and Highland, but also for lots of friends and family. It seems like all of my friends are either pregnant or planning to get pregnant soon. So I'm happy to be here and to be able to take part in the conversation tonight.
Excellent. And so can you talk to us just generally about COVID infections and maternal and baby outcomes?
Sure. So I think it's the COVID-19 infection in pregnancy has unfortunately been similar to many other infections where pregnant patients are just at much higher risk than the general population of becoming quite ill. And in particular, we know that there are certain complications specific to COVID-19 that pregnant patients are at higher risk for, like the need to be hospitalized, the risk of ICU admission, which is 6 times higher in pregnant patients, and unfortunately the risk of dying from COVID-19, which is many-fold higher among our pregnant individuals. And then there are also specific complications that only pregnant patients can have, like the risk of preterm delivery, which is impacts about 1 in 10 pregnancies in the United States, but the risk is 4-fold higher in patients who have COVID-19 infection and severe infection in pregnancy. We also see higher rates of preeclampsia, which is a specific condition associated with high blood pressures and signs of organ dysfunction related to the condition that unfortunately impacts those who have COVID-19 infection more often. And so it's, we've been very excited about the opportunity to vaccinate our patients who are thinking about becoming pregnant or are pregnant to help decrease this risk.
It's just heartbreaking, right? I'm sure that, as a physician, that every single story really gets to you because, pregnancy should be joyful. And so you had mentioned that you are trying to have conversations with people that are thinking about becoming pregnant. And there has been some conversation about vaccination and fertility. Can you talk to us about that? And is that a concern?
Yeah, and I think, the question around how does the vaccine potentially impact fertility started very early when the studies were still happening. And I think with a lot of rumors, it's really hard to trace back kind of where this myth or this idea came from. But with this particular rumor, there's a little bit more insight into conversations that started kind of early on around the similarities between the spike protein that the antibodies are designed to target with the vaccines and a protein that is on the placenta known as syncytia 1. There was some questions, including from a scientist who used to work at Pfizer, about whether similarities between these two proteins might make it such that antibodies directed to the spike protein might impact how the placenta forms or the ability for a pregnancy to continue. And what has been studied since these rumors came out is looking at the similarities between the codes for these proteins, whether the structure of them is similar, and there really doesn't seem to be very much similarity in the proteins at all, not enough to increase the concern for infertility or miscarriage, just based on sort of coding and looking at the structure of the proteins. We've also been lucky that researchers have looked at exposing these proteins on the placenta to the antibodies and haven't seen any signs of cross-reactivity. And I think the other thing that has been reassuring is the data on pregnancy outcomes in patients who've been vaccinated. So in the original randomized control trials, we actually, scientists were trying to enroll people who did not want to get pregnant or who weren't pregnant or planning to become pregnant. But as we know, a lot of pregnancies in the United States are unintended, and the rates of unintended pregnancy between the individuals who were randomized to get placebo and those who were randomized to get the vaccine were not different, nor were their miscarriage rates. And we've been fortunate to, through the CDC, be able to track data on patients who've received COVID vaccines, either around the time that they conceived or in the first trimester, and haven't seen any increased risk of miscarriage in patients who received the vaccine at less than 20 weeks. And I think the other group that has been really helpful in us understanding this information, or if there is a risk of fertility, are doctors who specialize in reproductive endocrinology and infertility, those who assist families who had challenges getting pregnant with reproductive technologies like IVF, and they recently had the American Society of Reproductive Medicine recently had their sort of annual meeting where a number of studies were presented looking at whether or not having antibodies impacts the how successful an IVF cycle is, and didn't see any difference. Have looked at sort of does having antibodies impact sperm quality, and didn't find any difference. So all of these things are very reassuring to us. I think what's important to keep in mind is, I think a lot of individuals aren't aware of the increase, that the baseline risk of miscarriage or these kinds of pregnancy complications, which are much higher than I think we talk about. It's estimated that anywhere between 1 to 2 out of 10 pregnancies end in miscarriage. So I think sometimes patients or individuals might hear of somebody who experienced a loss, and maybe they also happen to get a vaccine around the same time, but there's no data that the vaccines are actually increasing the risk beyond the baseline.
So let's say that I was pregnant and thinking about being vaccinated. When's the best time to do that?
I would say as soon as you're ready. I think it is really important for patients to feel comfortable. I think what we're hearing a lot from our patients is that they're feeling like they're not being encouraged to ask questions, that they're feeling bullied into getting the vaccine. And it's really hard. I think that there are, medications that have been around longer that we feel, very comfortable giving in pregnancy that patients decline. So it is your choice. But ultimately, I tell patients as soon as you're ready, whether it's you're seeing me for a preconception visit or in your first trimester, second trimester, third trimester, if I've delivered your baby and you're postpartum, as soon as you're ready is the right time. We don't have any suggestion that receiving it in the first trimester versus third trimester is better or worse. And we know that the sooner you get it, the sooner that you have protection against infection. And even for those who recover from COVID-19 infection earlier in pregnancy, there's some concern that there can still be increased risk in the pregnancy moving forward. So anything we can do to prevent infection is critical.
So there's really no ideal trimester.
Yeah, so there's not an ideal trimester, but again, I have conversations with patients about the fact that especially with miscarriage in particular, that sometimes patients will look back and sort of think that they did something that might have caused the pregnancy loss. Like maybe they shouldn't have taken that trip to Santa Cruz or whatever the case is. And it's really, for them, it can be quite challenging to disentangle anything that they could have done with that increased risk. So I make it clear to them that there's no evidence that getting vaccinated in the first trimester will increase your risk of infection. But if you prefer, we can wait until you're out of that first trimester window when the risk of miscarriage is highest, if that would provide the patient with sort of more comfort, but there's not a medical reason to wait. There were conversations earlier on about the fact that the side effect of fever could, potentially be associated with increased risk. We definitely try our best to avoid fevers or infections in pregnant people in general, but people who have really high grade fevers for prolonged periods of time in the first trimester has been associated with increased risk of certain birth defects, specifically with the spinal cord. But the duration of fever that is seen as a side effect of these vaccines is very short, and it's very safe to take Tylenol to treat those fevers. And so the chance of something like that causing long-term, problems for the pregnancy just hasn't been seen.
So I have two more questions for you. The first is that, can you explain how it is that if I was a pregnant mom and I got vaccinated, how is that going to protect my baby?
Yeah, that's a great question. So if you got vaccinated in pregnancy, the antibodies that are in your bloodstream, specifically the ones that you develop kind of with more time from the vaccine, are able to cross the placenta and circulate in the bloodstream of your newborn after they're out, the newborns are less likely to get COVID-19 infection, but everything that we know suggests that that would be a protective benefit to them. And then if you choose to breastfeed, which we encourage and support our new moms to do, then you secrete different types of antibodies, but antibodies do get secreted in the breast milk, and that the baby would have benefits because of that too.
So my cousin was pregnant during this pandemic, and she is breastfeeding and pumping and living with her parents. And I was telling my uncle, you should put some of that breast milk in your coffee. You get some good protection that way, because breast milk is like medicine.
It definitely has a lot of benefits, even beyond protecting your little one from COVID-19. But I'd suggest that the uncle gets his own vaccine.
He did. And so there's been some conversation about changes in menstrual cycles after vaccination. Can you talk about that? Is that real?
I think that the truthful answer is that we're not exactly sure. That there are lots of things that affect the menstrual cycle, including stress, exercise, diet, certain medications. And so it is something that, similar to like our energy levels, can be impacted by many things. We do have some data from studies of individuals who've had COVID-19 infection that shows that there does seem to be that there are some changes, specifically that it seems like individuals' periods are lighter but tend to be longer in duration. But also when researchers looked at just women in general in the pandemic, including those who did not have COVID-19 infection, a lot of them also noticed changes in their pregnancy, again, most likely related to stress and changes in like lifestyle issues. And with the COVID vaccine, menstrual cycle changes weren't really one of the side effects that were tracked in the randomized trials. And so it's just now that the NIH has funded researchers to really look at what impact the vaccines might have on menstrual cycles, as well as the infection. But I think the reassuring thing is that even from sort of anecdotal reports, that the impact seems to be on just a few cycles, which kind of makes sense. If there is something about the response that your body has that's generating these antibodies, and it maybe causes you to feel a little tired or have a headache, there's no reason to think that the uterus is like a protected territory that definitely won't get impacted in some way. But that we would expect that over time, as the lining resets for your next cycle, that it shouldn't have any sort of long-term side effects. But we're gonna be but in the medical field, looking at that more, just to be able to provide patients with more concrete answers.
Thank you so much. So I actually have questions for everyone. If everybody wants to come on camera, I do have a group question to ask. And so I'm going to start with Dr. Singh. And the question for everyone is, can each of you share what do you think is the single most important reason to get vaccinated?
Oh, so it's me. I would love for my kids to be able to see their grandparents. They live in Wisconsin, and one is travel, two is actually getting to spend time with them. And while young kids are, less at risk for COVID, agreed, I just want that mental peace of mind to go and just hang out with them, spend time with them. They're vaccinated, we are vaccinated, and the kids are vaccinated. It'll just make me feel so much better. Dr. Arcila would share.
So it's so hard to nail it down to just one single thing. I mean, I feel like I have two really important jobs. Number one is to care about my kids, and number two is to care about your kids. And I tell my kids all the time that my most important job as their mother is to keep them safe. And COVID in their age group, age 5 to 11, was one of the top 10 causes of death in the past year and has now made its way up to number 6. And so just like I buckle them into their car seats on the rare chance that we might get into an accident and that might save their lives, I absolutely got in line last week right away when I could to vaccinate my kids and keep them safe. You know, I've seen the kids that get the sickest from COVID. I've seen the kids that get the sickest from MIS-C, and my kids were in the hospital as neonates for 2 weeks, and I wouldn't wish that experience on anybody. And so for me, keeping them safe and keeping my patients safe.
I might be next. I think the thing I would say is that each of your decisions matter. How you choose to protect yourself from getting COVID-19 impacts how protected others are around you. And just to piggyback off of Dr. Silla's point that, you know, it saddens me and others in my profession deeply that, you know, October was the most deadly month for patients with COVID-19 infection and pregnancy, and that the reality is that all of my patients and their families really want the good outcomes for their loved ones, and that it really is sad when their cousin or friend or partner are the ones that transmitted the infection to them, or that they were not vaccinated and got really sick and had an outcome that they didn't ever anticipate in the pregnancy. So I just really encourage people to recognize that the decisions that you're making that impact others, and that I'm really thankful that you all are here tonight, making sure that you're making informed decisions and asking questions that help you get there.
Thank you so much. So I have one more audience question. And Dr. Singh, I do believe this question is directed towards you. And so how is vaccinated immunity now better than natural immunity, when in the past it's been typical that natural immunity is better? I have to raise my hand and share with you that when I was young, my sister got the chicken pox and my mother made me sleep in the bed with my sister, and then I got chicken pox too, and she felt like that was a great thing. And so can you kind of explain the thinking?
Yeah. So two approaches to it. The one, I would slightly try to modify what we say about natural immunity. In fact, what I would encourage people to say is infection-induced immunity versus vaccine-induced immunity. So you need to be infected in order for you to get immune to it or to create those natural antibodies. And that's right now, we don't know or can specify, except for a few exceptions, saying that, you know, obesity is a risk factor for you to develop severe disease. There are certain things where we kind of find it to be unknown, like which kids are going to develop MIS-C, which kids are going to go on to be hospitalized. And as if you remember, seems like such a long time ago, but when I shared the slide, about 50% of the kids had no underlying medical condition, right? So if I were to kind of play odds, I'm not a gambling person, but I would just pick, vaccine-induced immunity because it reduces my odds for getting hospitalized, for getting long COVID symptoms and other things. And then if you really go into the science, sort of like when they have actually done studies looking at infection-induced immunity versus the vaccine-induced immunity, the antibody titers and other things that you develop after vaccine-induced immunity seem to be, at least right now, suggest that you have a longer duration of time that you're protected against the virus. And not only that, you're protected against the severe complications from the virus. And so that would be my approach. And yes, traditionally, that was our thought as well, that natural is best, like we would want to do that. But in this case, I kind of hesitate to go the natural route and that's why I encourage people to say infection-induced immunity, not natural immunity.
Thank you so much for that answer. And so it's cough and cold season. We all know that a lot of our kids have runny nose and some coughing. As a parent, should I get my kid COVID tested a few days before they get their vaccine to ensure that they're not infected with COVID when they also get their vaccine?
That's a great question. And I actually took a pause when I did read that also. I was like, I wonder if that would be, and perhaps right now as the testing is, you could, and that would provide you with reassurance. And of course, if you are COVID positive, you wouldn't want to go into a vaccine center to be exposed to other people. So yes, if your child is symptomatic with fever or runny nose, perhaps call your pediatrician beforehand and ask for recommendations as to how they could go about testing. But if your child does not have COVID and they have a mild runny nose and otherwise they're rambunctious and full of energy and no fevers, then perhaps COVID vaccine is not gonna, it's safe to do it.
Great, thanks. I have one more question. And so are there any facts about how vaccination affects younger children who are still growing, right? Are there any known negatives about physical development on children? And do we know if the vaccine will influence any of these genetic factors about obtaining optimal height and growth?
Right, and this is where I would say it's a testament to perhaps us as largely vaccinated community that got vaccinated 10, 20 years ago, perhaps not with COVID, but certainly many other vaccines that have been safe, and they have not shown that we are largely, growth stunted society or other, risk factors. So I feel like I would say that if somebody would ask me, can you show me a longitudinal study about COVID? Well, COVID has been with us for 2 years. So no, there's no longitudinal study. But if I were to use my scientific mind and say, derivatively speaking, other vaccines have not shown anything, and this vaccine doesn't seem to be any different than others. So I would not worry about long-term side effects, especially in terms of growth and development. 100%. I don't have that hesitation in my mind at all. I don't know if anybody else wants to weigh in on that, but that.
So just to clarify, you're saying that it doesn't change your genetic makeup, your DNA.
It does not change your genetic makeup. The vaccine, the way it's produced, if anybody really wants to I can go into the details of it, but it produces a recipe to your brain, to your cells. And that's what it says. Like, here's the recipe. I'm going to generate the proteins, and your cells generate, and that degenerates within a couple of hours to days. That vaccine component does not stay in your body, does not stay in long term, does not integrate with your DNA, has zero.
Wonderful. Thank you so much. Dr. Singh, can you please show the last slide? And I'm going to wrap us up. And so I want to thank everyone for joining. There is a recording of tonight's event, and that recording will be posted in a few days. I also want to direct people to where they can get additional information. And so if you are a San Francisco resident, you can use this code and get more information. We also, when we post the recording, we also will have links for where you can get more information. We also have this code for Alameda County. We do have some information around the COVID vaccine that we also will be sharing with you. And I thank everybody for your time and attention. I want to thank all the experts for just sharing your wisdom with us. Thank you so much.